Officially start recording. Perfect. So we are now officially recording. So for those of you who are here with me for the first time, I like students to be active. I like students to unmute, ask questions, of course, participate any way you can. Type in the chat, unmute yourself, feel free. After we finish the webinar, the content, we do our review questions, and then we'll be done for the evening. Okay, so I'm going to be sharing my screen now. Okay, there we go. So these are our objectives for the evening. Okay. As again, we're going over strokes, seizures, traumatic brain injuries, and of course, intracranial pressure, which is a part of traumatic brain injury management. So, first things first, what is a stroke? Okay, so stroke, we can also call it a brain attack. Anytime you have an interruption of blood flow to the brain, there's a risk for a stroke. And interruption comes from a lot of different things. You can have blood clots that travel to the brain and block blood flow. You can have a client that's hemorrhaging. Okay, if there's a traumatic loss of blood, then of course there's loss of blood flow to the brain. Medications can cause possible risk for a stroke. Other pre-existing conditions can increase the risk for a stroke. So anytime you have a loss of blood flow to the brain or a lack of perfusion, if you want to look at it that way, there is a risk for traumatic brain injury or, I'm sorry, not traumatic brain injuries, a stroke. The concern when it comes to a stroke is how long is the brain going without oxygen? That is a big question because when it comes to a loss of perfusion, there's a loss of oxygenation, which is a loss of oxygen. And it takes the brain about 4 minutes to start suffering from irreplaceable damage. So the brain, unfortunately, is the only organ that does not repair itself after injury. The heart can repair itself after injury, depending on, how severe the injury is. The heart can, be repaired. The liver can be repaired. Your other vital organs can be repaired after some type of an injury. The brain, unfortunately, when it reaches a certain point, there is irreversible damage. And when it comes to loss of perfusion or loss of oxygenation, 4 minutes is all it takes for the brain to start suffering from damage that are irreversible. So when it comes to stroke management, we want to be on top of it. Okay, we want to be able to recognize it quickly as nurses, recognize it quickly, of course, implement protocols. Most hospitals, most healthcare facilities have stroke protocols. So the best thing for you to do is once you start working in a facility, learn the protocols because the quicker you act, the quicker you can save the client in terms of irreversible damage. So these are your types of strokes, okay? Ischemic and hemorrhagic. And then you have transient. We'll be talking about ischemic and hemorrhagic. As you can see, transient is kind of sort of the same as ischemic. So we kind of group that into there. So ischemic stroke and hemorrhagic. Those are the two types of strokes that we will be discussing tonight. So first up, ischemic stroke. This is a type of stroke that occurs when there's a blockage of blood flow to the brain. So think a clot. Okay. One of the most underrated or underlooked complications of blood clots is a stroke. Okay. We're always so concerned about the risk for a PE. What is a PE? If I say a person is at risk for a PE due to a clot, what is that?
Pulmonary embolism.
A pulmonary embolism. Thank you so much. Yes, it will be beneficial, Miss Jayla. I just saw your question. It absolutely will be. One thing you guys have to keep in mind when it comes to the NCLEX, okay, when you sit down for the NCLEX, I'm just stopping to answer Miss Jayla's question. When you sit down for the NCLEX, keep in mind you have no idea what is going to be on your test. You have no idea. You're just going to sit down and start answering questions. That means your questions can come from any place. Adult health, mental health, peds, maternity, geriatric, pharmacology. It can come from anywhere. The best for you to prepare is to just be well-rounded when it comes to the content. Okay. Since the content could be anything, you just want to be well-rounded. You want to be comfortable with whatever you may see on the test. Even if you don't know the answer right away, at least be comfortable enough to try to answer the question as best as you can. So yes, any of the webinars that we provide, the resources that we provide is definitely going to be beneficial for you when you take your NCLEX. You're welcome. Okay. You guys don't be afraid to type questions in the chat. I do check the chat periodically. So I'm not sure who said the answer, but you are correct. When we talk about PE, we're talking about a pulmonary embolism. That is when a clot travels to the lungs, and then you start experiencing the signs of respiratory distress, which can be deadly. Now, the same thing can happen with the brain. If a clot travels to the brain and blocks blood flow to the brain, there's a risk for a stroke. You may also see the letters TIA, transient ischemic attack, same thing. You may also see the letter CVA, cerebral vascular accident. Those are all different ways of saying stroke or stroke-like, condition or activity. Ischemic strokes are the most common types of stroke. So 85% of people who have strokes, they are having an ischemic stroke, which means lack of blood flow. Okay. Again, it is typically caused by a clot. However, there are other things that can cause blood flow to be blocked from the brain. Things like hypertension. You have to think about it. When you have hypertension, what happens to your vessels? Someone tell me, if I am hypertensive, what's going on with my blood vessels? They are doing what? Or what state are they in?
They constrict.
They constrict. Yes, ma'am. Thank you very much. When you have constriction, okay, you have a lack or decreased blood flow. So that is another way you can have a decrease in perfusion to the brain, conditions like hypertension. Ischemic strokes, they are medical emergencies. Okay, again, it is crucial for nurses to be the ones to promptly recognize a client is having a stroke. A lot of people have subtle signs of stroke and they don't even realize they're having one. So, unfortunately, if you're not aware of what the signs and symptoms look like, then of course you're not aware that you're having it. You waste valuable, precious minutes when it comes to treatment to restoring the client's health or preventing irreversible damage from occurring. Okay. And again, the goal is reducing the risk for a long-term disability, which comes from irreversible brain damage. And then we have our hemorrhagic strokes. Okay. These are the types of strokes you see when there's a rupture of a blood vessel. Okay. Unfortunately, when you have a ruptured vessel, you have bleeding around the brain. So this is not blood getting to the brain in terms of perfusion. This is blood that is bleeding out around the brain. So it's almost the same thing. You are not getting perfused appropriately. It's just the method changes. So when it comes to ischemic, we're talking about clots. When it comes to hemorrhagic, we're talking or blockages. When it comes to hemorrhagic, we're talking about ruptured vessels, bleeding vessels. Okay. Hemorrhagic strokes, not as common as ischemic, only 13% of all types of strokes are classified as hemorrhagic. They still require the same, medical attention as ischemic, no matter how rare they are or how often we see them or don't see them. You still have the same urgency when it comes to treatment. Recognize it soon. Start treatment promptly, reduce the risk for a long-term disability or irreversible brain damage. Immediate treatment is crucial. So we will talk about managing a stroke. Okay. Again, most facilities have a protocol to follow. It's pretty much all the same. So typically, regardless of where you work, the steps of recognizing, treating strokes are pretty much universal. So risk factors. Okay. Now this is where the education comes in. On your NCLEX, you're going to definitely have a lot of education questions. Okay. We have to be able to educate our clients. Health promotion, reducing the risk for things happening if they do have a condition, educating them on management, the medication they may take, the therapy they may have to do, the labs that we do. You have to be able to explain, okay, when it comes to certain conditions, because that is a part of your nursing responsibilities. So when it comes to understanding risk factors, okay, if I am going to educate a client or if I'm going to educate, let's say, a group of other nurses about what the risk factors for stroke, these will be the main things that I would talk about. Okay, heart disease, huge, huge, huge risk factors for stroke. Okay, hyperlipidemia. Does anyone know what that means? Hyperlipidemia.
Cholesterol.
High cholesterol, exactly. Okay. So someone who has poor diet, okay, leading to high cholesterol. Obesity is a risk factor. Okay. A lot of times with obesity comes the coexisting conditions, such as hypertension, diabetes. Okay. Hypertension being a huge risk factor for strokes. Okay. That's why we have heart disease, not just hypertension, vascular diseases. So again, if you have coronary artery disease, okay, You have your risk for your ruptured vessels. So that falls under that. People that are sedentary. When you have a sedentary lifestyle, you're not very active. Okay. And if you're not very active, there's a chance that you can be obese. So it kind of goes hand in hand. We want clients to have some type of activity, even if it's just a walk, 30 minutes a day, 3 days a week, at least get active or encourage the client to find something that they like to do. A lot of people be surprised of the activities they enjoy doing if they at least try it. Okay. Smoking. Now, if I was to ask you, what is it about smoking and the relationship to the risk for stroke? What you guys think that risk or that link is? Smoking and stroke risk. What can smoking do? There's a big ingredient in cigarettes that is the main culprit for increasing the risk of stroke. What would that be?
There is this thing in the smoking called
Nicotine.
acid, nicotinic acid, and that one hardens the blood vessels and therefore let the blood pushes hard. It has to exert more energy to pump the blood through the vessels because the vessels becomes very hard. Yeah, and that causes.
Yes. Okay. Well. Okay then. Okay. Who? Patience. Okay.
Yep.
Yes, ma'am. All of that.
So
And then
it can
somebody
cause
else
heart
said
disease
nicotine.
and lungs disease too.
All of that. Yes. Look at y'all on top of it. I love it. Somebody said nicotine. That's a big factor. Nicotine causes vasoconstriction. So think the same thing like hypertension, the same concept. So with nicotine, you can have a reduction in blood flow, again, increasing your risk for stroke. We already
Mature
said
aging also.
aging. And you know what? That's something that we don't think about. That is natural causes. So we seem to be so focused on, the risk factors in terms of diseases and in terms of, poor diet and lifestyle. We don't think a lot of these conditions are just age related. Okay. It's nothing that you can do because you can't stop aging. No matter how many treatments or, how well you diet and exercise, you can create a healthy body. However, you cannot reverse aging, no matter how hard we try. Okay. People think that they can, but you really can't, reduce or stop aging. So that is something naturally that places a person at risk for stroke. And some people don't like to acknowledge the fact that they're getting older and their health is declining, but that's just natural part of life. And if you you approach the subject with respect, because it could be a sensitive topic for a client, then of course you probably can get the education across a bit easier for them to take. Okay. It's like, explaining to a woman that she's going through menopause. It's a very sensitive topic, and you have to be respectful of the client's feelings when we're talking about things like aging and the risk factors that comes with aging. So recognizing stroke. So the acronym BFAST, one of the things that's going to help you guys, especially with the NCLEX acronyms, okay? If you can throw together an acronym to help you remember stuff, listen, that'll make your life so much easier, okay? And you can do your own acronyms. You can always find acronyms through your resources, but an acronym is a very shorthand way for you to remember information. And the acronym BFAST is going to help you recognize a client having a stroke. Okay. So B stands for balance. One of the things that we notice when a client or individual is having a stroke, okay, they may have a loss of balance. Okay. It's really neural. So not only do they have a loss of balance, they could also complain that they have a headache. Okay, dizziness. Those are things that can lead to a loss of balance. Okay, or unfortunately, they may fall. Okay, and they fall uncharacteristically. It's like, why are you falling? Why are you so unbalanced? Why are you kind of wobbling, holding your head? Those are little, warning signs of things that we look for. And then we talk about the eyes. Okay, if the client is able to verbalize, they will tell you blurred vision. Okay, that is one of the biggest signs and symptoms for having a stroke. The vision becomes blurred all of a sudden. Okay, facial drooping. Facial drooping. That's a huge one. Okay, some people, depending on which side of the brain is affected, Okay, you might notice facial drooping on one side. It's not normally a double-sided thing. You will notice facial drooping on one side or facial paralysis. Okay, if you notice one side of an individual's face drooping, huge, huge, huge red flag. Okay, their arms or their legs become weak. We call it paraplegia. Okay, they lose weak, they lose functioning, they become weak. There's a risk for injury, falls. Okay, their speech becomes incoherent or it's difficult for them to talk. Okay, we call that aphasia. If you talk about other mental health conditions, Parkinson's, dementia, over time as the client, progresses, they start having trouble with communication, and the person may talk, however, the speech may be incoherent. Okay, or because they have difficulty talking, if you're talking to them, now just because they're having difficulty talking does not mean that they can't comprehend. Okay, it's not always, I can't talk, I can't comprehend. Sometimes the client can comprehend just fine. They just have trouble expressing themselves. So if I need to communicate with that client, I need to position myself so that they can see me talking. Maybe they'll be able to read my lips. You don't have to talk loud. Okay, so we're not saying that the client loses their hearing. You don't have to talk loud. You don't have to over pronunciate. That could be a little bit offended to the client. You just have to, stand in front of them, talk clearly like you normally would, but talk clearly so they can at least try to visualize what it is that you're trying to say. Because again, they can hear you. They just might not be able to communicate it back to you. Okay. And then lastly, when do I need to call for help? Immediately. Okay. Now, best case scenario, if the client's already in a healthcare facility, we can start initiating treatment protocols right away. But if this person is, let's say, home, they have a caregiver or themselves, this is how you know you're experiencing a stroke. You need to call for rescue services ASAP. Remember, when it comes to a stroke, there's only a couple of minutes you have. It's like a little window of opportunity. Okay. And the quicker you act within this window, the better the chances of you, protecting the client from irreversible injury. Okay. Next, we talk about diagnosing a stroke. So there's different things you can do to diagnose the stroke. It's a little more than just recognizing signs and symptoms. The NCLEX likes things that are definitive. Okay. You might, we know what we're looking at. Like, I know what this is. I can see it. However, that is not enough to definitively say anything. Okay. You have to be able to have some type of data to back up, what it is that you're thinking the client has. Because remember, as nurses, we don't diagnose. That's not within our scope of practice unless you have an advanced degree to do so. Now, we can recognize stuff, or we can, what does the nurse suspect the client is having, or what does the nurse suspect is going on? See, we can always have suspicions and we can always analyze, but an official diagnosis, we don't do that. That's not in our scope of practice. So you may see questions, the client is exhibiting XYZ symptoms. What does the nurse suspect the client is experiencing? Okay, I believe this is a stroke that I'm looking at. The client has this symptom, the client has that symptom. These are all clinical manifestations. I'm pretty sure this is a stroke. Being pretty sure is not enough. You have to officially or definitively diagnose. Okay, and that is where this comes in. We can always do an assessment. Medical history, your risk factors. We can always do pre-existing medical history. Do you have any condition that could increase the risk of you having a stroke? We can always do a physical exam. Okay. I might want to see functioning. How well do you walk? If I ask you to pick up a pencil, could you pick it up? Because what if you have paralysis on that side? If you are right-handed, I'm going to ask you to pick up the pen with the right hand. Even if you're right-handed, pick it up with the left hand. Okay, I need to be able to assess if there is paralysis on either side of the body. Of course, looking at the face also to see if there's drooping on one side. Then you go into your exams. Okay, this is when you start definitively diagnosing strokes or other CVA type activity. Images. Okay, sometimes we want to see, what area of the brain is affected, how severe that side is affected. Okay, so we start doing imaging exams, CT scans, MRIs, very, very important. Okay, and EEG, probably the hallmark for definitively diagnosing a stroke. Okay. And EEG measures electrical impulses. Okay, so if you ever saw somebody with the electrodes all over the head, we are looking at brain activity. And in EEG, it diagnoses a bunch of different things related to the brain. Okay, a lot of times, if you have a client with a traumatic brain injury, which we will talk about, I need to know how severe this injury is. Okay, is the client beyond saving? The EEG will help to determine that. Is there any brain activity? So, a lot of times you hear stories about people being declared clinically brain dead. That is because there is no detection of electrical impulse or activity. Okay. Labs. We also want we want to know if there anything blood related that increases the risk for a stroke or can help define what type of stroke you may have had. If you have clotting issues, definitely that could be a reason why you had a stroke, ischemic stroke. Okay. If you have an increase in clotting factors for whatever reason, okay, you are at risk for having a stroke, or it can help determine what type of stroke you had. We also look at electrolytes, believe it or not. Okay, client with electrolyte imbalances, big risk for having CVA type accidents or strokes. Okay, more specifically, which electrolyte you think I'm gonna probably pay attention to the most if I am concerned about a client's risk for a stroke?
Potassium.
Potassium
And sodium.
and
Now,
sodium.
potassium is more for cardiac abnormalities. Okay, but potassium does follow behind sodium. So both of those could be instrumental in helping me to determine what's going on with my client. And now you have your treatment. So client has been officially diagnosed with having a stroke. The EEG, the images, they all have come back and help define the diagnosis. Now, okay, we get into the treatment. Now, keep in mind, okay, in the real world, in the eyes of the NCLEX, you do not have to wait for an EEG result to start treatment. Remember, at the first recognition of the signs, you need to jump into action because that is your priority. The NCLEX loves a priority question. Okay, if you recognize a stroke, even if you're not diagnosing it, because as nurses, again, with a basic RN degree, we do not diagnose. Okay, but we can recognize. You do not have to wait for a definitive diagnosis to start implementing treatment. Okay, it is not going to hurt the client if you implement stroke protocols, even if they're not having stroke. So treatment comes as soon as you recognize the symptoms. Make sure you keep that in mind. Okay, of course, you have your medications. This is totally depending on what is causing the client's stroke. Okay, IV fluids, that is considered a medication. You want to start them on IV fluids as soon as possible. If they are having, because of, clots, okay, we might want to start them on medications to prevent future clots. What type of medications would those be? If I need a medication to prevent my client from clotting further,
Heparin.
Venous.
No,
TPA.
Anticoagulants.
okay, now TPA, I'm glad you said that. That is a medication to treat clots. So we're talking about medication to warfarin, heparin. Yes.
Byron.
So that would be to decrease the risk for further clots happening. Now, the client could already have a clot. That's one thing. But if I want to reduce the risk for further clots, the heparins, the warfarins, and all that good stuff. Now, somebody said TPA. Okay. TPA is a type of a therapy medications where you're trying to quickly dissolve clots. Okay, that is also a very important medication, and those types of medications we use for ischemic type stroke. So the TPAs, that's another thing you need to remember. It works for ischemic strokes. Okay, if you're having a hemorrhagic stroke, TPA will not be a benefit.
no.
Can we give heparin and Coumadin? You could. I mean, in theory. Now, is it recommended? Probably not.
Yeah, because you're already bleeding, so you don't need to
There
put
it
it back.
is. Listen, it probably would be a good. It wouldn't be a responsible thing to do. I mean, you could always do it. Now, if that's the question that you're asking. Should you do it? That's a whole nother question. You should not. Okay. Also, when it comes to which one to use, again, it totally depends on the client situation. I mean, they both do the same thing. However, heparin, of course, would probably be the first drug of choice. for preventing further clots. Okay, so again, TPA helps to dissolve clots that are already there quickly. Okay, and again, if you have an ischemic stroke, that would probably be the way to go. A thrombectomy, that is when we're going in to remove a clot. Now, this is helpful if you do your imaging studies and you see where the clot is. Okay, not only can you see the clot, but it's in a place that's easily accessible. Okay, so a thrombectomy, that is beneficial again when I see the clot and is in a place that's easily accessible. Okay, that will probably be a quicker route to get rid of the clot than TPA and ischemic strokes. However, again, if it's not in an accessible spot, then the risk might not be worth the benefit. So that is where the TPA will come in. Okay, angioplasties. If you have vessel issues, cholesterol, fat buildup, okay, when you have plaque that builds up in vessels from things like coronary artery disease, hyperlipidemia, high cholesterol, plaque buildup can obstruct blood flow. So sometimes you can do procedures like an angioplasty, to kind of open up the vessels using a stent to keep that in place and keep that vessel nice and open, to kind of direct blood flow back to the areas it needs to go. Then, of course, the lifestyle modifications. You may need to lose some weight. Okay. You may need to eat better, lower the fatty foods, the oily foods, more fruits, more vegetables. Okay. Cut down on your carbs if you're diabetic. Cut down on your salt if you're hypertensive. Okay. Get moving, get active. Try not to be so sedentary. Okay. I have had clients, they don't like to go outside. You don't have to go outside to be healthy. I mean, it's recommended you get some fresh air, but if you're just that type that don't want to leave, listen, you have so many different things you can do in the home. One of the things that I like to use, and it's fun for me, I had brought my son, oh God, an Oculus, those virtual reality headset things. And I was playing around with it one day, and I didn't realize how much stuff you can do in the Oculus. Like they got workout apps, the scenery, you can work out in the mountains. Let me tell you, I've been working out all over the world, child. I'll be in Paris, I'll be in London, just working out, walking and working out. And that's, for me, that's fun. I probably enjoy that more than just going outside and walk around the block. So you have to sometimes help your clients find ways, activities that's fun for them. Okay. You can get a little mini treadmill and just walk on the treadmill while you're watching your favorite TV show. Okay. TV show is over. Next thing you know, you didn't walk 30, 45 minutes, an hour, and, watching TV. Okay. And then rehabilitation. Now, one of the things that could be on your NCLEX is prevention strategies. Okay. And this is something you may have learned either in fundamentals or med surg. When we talk about prevention strategies, there's 3 levels: primary, secondary, tertiary. Okay. When we talk about primary prevention, we're talking about strategies that prevent you from getting sick, or strategies that prevent or reduce the risk of something happening. So a good primary prevention would be vaccines. Okay. When it comes to strokes, before I have a stroke, because I know I'm at risk for it, let me improve my diet. Let me start exercising, let me, do this, let me do that. Okay. That is prevention before I get sick or before I have my stroke. Secondary will be screening. Okay. Those are the imaging tests that you do. Rehabilitation, unfortunately, is tertiary. So unfortunately, the event happens. It's nothing that we can do. The only thing that we can do is try to get the client back to their optimal health. When it comes to a stroke, that depends on how, massive was the stroke, how much of the brain was affected. So a lot of times when caregivers have questions, what's going to happen? Are they going to be okay? Unfortunately, you don't have that answer right away. And this is therapeutic communication, which is also an NCLEX. How do you properly respond to those types of questions? Okay. Will my child be okay? Speech therapy. Oh, a lot of times you have to bring in a therapist. Yes. Sometimes you can't make a definitive diagnosis of how severe the client's condition is. You have to bring in other experts to give their input. Speech therapists, OT, okay, PT. These are all professionals, that will evaluate the client and give their recommendations for in terms of rehabilitation. Sometimes the clients can go home, they had a mild stroke, nothing massive. brain, everything looks good, they can go home to recover. But if you had a massive stroke and a lot of the brain areas infected, you may have to go to a rehabilitation center. Okay, so rehabilitation totally depends on the severity of the stroke that the client experienced. And at the bottom, I have in bold, it takes 4 minutes for irreversible damage to the brain to occur from a lack of oxygen. That's all you have, 4 minutes. Okay, think about, if someone was drowning, 4 minutes, that's all it takes. Okay, so from a lack of perfusion to your brain, whether it is from a clot or whether it's from bleeding out, you have 4 minutes to restore that function before your client starts experiencing irreversible brain damage. Okay. So after a stroke, this is also important. Remember, rehabilitation is a huge part of stroke management. Okay, you definitely going to send a client to rehabilitation services. This can be in a facility or they can have home care come in, however often a week and work with the client. Again, it depends on the severity of the stroke activity. Okay. If the client has paralysis, which a lot of people from a stroke do suffer, and they may not ever gain full functioning back, they could be at risk for injury. Okay, because of paralysis, they could be at risk for skin breakdown if they are immobile. They can't move around like they used to. If they try to move around on their own, they could fall. So they are at risk for skin breakdown. That means as the nurse, I also have to keep, skin integrity. I have to reposition my client if they are immobile or bedbound. And then, of course, the inability to communicate. Again, depending on the area of the brain that was affected with the stroke, that is going to determine the type of symptoms that you see. What if the client does lose the ability to speak or communicate? That is called aphasia. Okay. Again, you see it a lot with Parkinson's, you see it a lot with dementia, and you will see it with stroke depending on the area of the brain that is affected. Hemiplegia, same thing. Paraplegia, hemiplegia, all of that. Yes, paralysis. And you have to assess the degree of it to give the client a functional assessment. Okay. Clients could sometimes remember, you can have a mild stroke. So the injuries, the signs and symptoms, the rehabilitation is not going to be as complex if you have a mild stroke. Okay. Reducing the risk for a second stroke. If you had one, you can have another, especially if it's from blood clots. So that is where the heparins come in. Okay. That is where the TPA comes in if the client has an ischemic stroke. Okay. Modifying the home. If your client unfortunately has suffered some type of a permanent disability, you have to set the home life up to, be appropriate for the client. If they are at risk for falls, no loose rugs, well lighted areas. Okay, put night lights around the home so the person can walk and they can see. If the person is in a 2-story home, is there any way that their bedrooms or where they sleep could be moved downstairs? Okay, those are the types of things we look at. We go into the bathroom, are there handrails? Do we have to raise the toilet seat up or do you have to have a bath chair? Okay, you have to do a functional home assessment if you have a client that experienced, a permanent disability due to them having a stroke. Prioritizing mental health. Okay, some people, their body is different. They are severely limited in things that they can do. It could affect the well-being. Okay, it is not uncommon for people who suffer permanent disabilities to go into a depression. So I have to assess my clients' mental health, and support groups. Listen, I love a good support group. If you can put someone in a room with other people that understands and they can share their stories, sometimes you might learn something. You meet people that's just like you that get it. Because sometimes it's hard to find people to talk to if they don't understand what you're going through. So a lot of times we want to support our clients, not just from us, but from other people that they could possibly relate to. And for the nursing management, so first thing up, prompt recognition. Okay, remember, be fast. You need to be on top of it. If you see anything that looks like it could remotely be a stroke, remember, you do not have to wait for labs, for imaging studies to confirm. You only got a couple of minutes to jump into action. So you would rather be safe than sorry. If the client's not having a stroke, it's not going to hurt them for you to implement stroke protocols. They'll be fine. Okay, complications, meaning further irreversible brain damage. Rehabilitation management, you may need to help coordinate services. Psychological support. Worst case scenario, someone suffers a massive stroke and it severely limits their quality of life. So now we have to transition into hospice, end of life care. Okay, there's a psychological component to that, dying with dignity. Even if the client is not able to do things 100%, they still need to have their rights respected. Okay, vital signs, always huge. Okay, blood pressure, O2 stats, pulse, breathing rate. All of those are important if I'm monitoring the health of my client that had a stroke. Okay, neurological signs. You can do little bedside things to check a client's neurological status. How alert are they? How oriented are they? Do you know who the president is? Do you know your name? What month? Where are you? Okay, assess levels of consciousness. All of that. You can do that without having to wait on those big tests like your MRIs, your EEGs. Okay, and also you want to coordinate. Okay, you always anticipate. You're going to see questions like that. The nurse anticipates the physician ordering what, or the nurse anticipate what happening. That shows you're understanding what's going on with the client. Even if you can't make that order, even if you can't make that diagnosis, it's not saying that you don't recognize it. It's just saying based on your scope of practice, that's probably beyond what you're able to do. But at least I can recognize and I can say something. This looks like the client is having a stroke. Okay. Or I would expect the doctor to do XYZ. Because guess what? Sometimes doctors slip up. It is what it is. They don't know everything. So a lot of times it's you, the nurse, that has to catch that because you are the advocate for the client. Okay. So recognizing, it's nothing wrong recognizing signs and symptoms, and of course, jumping on it to prevent the risk for further damage. Any questions about strokes? Any questions? Okay, so it is 9:50. Let's take our first breather, 10 minutes. So it is 9:50. We're going to take a 10-minute breather. So those of you, you're just going to get quiet because every time we take a break, I see someone asking, I can't hear anything. And then somebody like, because we're on a break. So we're on a break, 10 minutes. Okay, you guys. So we'll be back at 10 o'clock to cover seizures. Thank you, Miss Jayla. Thank you. I try. I try. So we are back. We will now jump into, let me see what's going on in the chat. Okay. We're now going to jump into seizures. Hopefully everybody's back and ready to go. Let me just check the chat to make sure. Okay, perfect. Okay, so seizures. So when it comes to seizures, a couple of things you need to know for testing purposes. Main thing, of course, what to look. Yes, we're ready. Main thing, of course, what to look for and what your nursing responsibilities are. Again, okay, when it comes to diagnosing a seizure, again, that is out of our scope of practice. However, we know a seizure when we see a seizure. Okay, so you're acting based on your nursing knowledge. Keep that in mind. So, what is a seizure? Okay, now we know there's different types of seizures. Whenever someone thinks about a seizure, they think about the common things that you see, the activity, the convulsing, the shaking, falling to the ground, the flopping. Yes, you have seizures that are like that, but not all seizures are like that. Some people have a type of seizures that you won't even know they're having a seizure because the symptoms that you would expect to see are very vague or absent. Okay. But basically what it boils down to is there is an abnormal like electric current going through the brain. That is pretty much what a seizure is. And depending on where that is located or depending on the severity of that abnormal electrical activity, that is going to produce the type of seizure that your client will have. Some people have a condition called epilepsy, which we will talk about. Epilepsy is an actual seizure condition. Okay, you can have a seizure, but it's not related to a condition. You can get struck in the head and you can have a seizure. You can have a very high fever and you can have a seizure. You can have an electrolyte imbalance and you can have a seizure, like dehydration. So you can have a seizure that's unrelated to having a condition, and then you could have a seizure type condition. For the most part, if you figure out what is the underlying cause of the seizure, okay, and you treat that, you can treat the seizures themselves successfully. So you have two classifications of seizures, or two, I won't say type because we are going to talk about types, but two sets, or again, classifications. Okay, you have generalized seizures. These are seizures where it is happening in both hemispheres. Because remember, if you go back to anatomy and physiology, you have two brain hemispheres, the right hemisphere, the left hemisphere. So when it comes to the brain activity, when you have a generalized seizure, it's pretty much all over. It's not, specific to the left or to the right. Okay. These type of seizures generalized, the person may lose conscious briefly. So it is common to see a loss of consciousness. The activity that you see when you do your brain activity to kind of diagnose it, you're going to see that the electrical activity is pretty much uncontrolled all over the brain. That is one of the factors that we look for when we diagnose epilepsy, one of the factors. But again, the activity is just all over the place. It's not well controlled, and that's why they're called generalized. Okay. Now, on the flip side, you have your partial or your focal seizures. Okay, this type of seizure is only occurring in one area of the brain. I can pinpoint that area. Once I do my imaging and my studies, we can see it is this area of the brain. This right here is where the seizure is occurring. In most cases, they will not lose consciousness. Okay, there is something called a post-seizure sleep that a lot of people go through when they have a certain type of seizures. They appear to lose consciousness. It's not necessarily they lose consciousness, in a sense that you would think. They just go into a post-seizure type sleep state. Okay, and we just normally let them sleep it off until they regain consciousness. Now, with a partial seizure, these are the types of seizures where you can miss the signs. Okay, there is one type of seizure where you won't see any signs or symptoms. It's called an absent seizure, which we will talk about also. Like the person just appears to be normal. You wouldn't even think they're having a seizure. Okay, now the only thing it might show you a red flag if I'm calling your name, I'm like, hey, so and so, and you're not answering. You're awake. I'm looking at you. You're not asleep. You're awake, but I'm calling you. You're not responding. You're like in a catatonic state. Those are seizures also. And a lot of people don't even realize that they have them. You ever notice you might have called somebody and they like snap out of it? Okay, that could have possibly been a seizure. We don't know, but those are the types of things you see with certain types of seizures. Now we get into our types. Okay, now the names of the seizures have changed. They're still the same type of activity in terms of descriptions, but we do refer to them as a different way now. So you have what you call generalized onset. Okay, now we call it a tonic-clonic seizure. It used to be known as grand mal seizure. You may have seen that term before. This is the typical type of seizure that people are most familiar with seeing. Okay, the body convulsions, the flailing around, those are the typical. So if you ask somebody to describe a seizure, most times people will describe a tonic-clonic. Okay, and then you have an absent seizure, brief period of blinking out. Okay, daydreaming, staring off into space, not blinking. Those are your absent seizures. And they're called absent because, again, you don't necessarily always catch it. Okay, anytime you hear things about kids that's always daydreaming, they're not paying attention, they're daydream, they don't focus. Is it ADHD? Is it they're just not interested, they're not challenged, or are they possibly having an absent seizure? Okay. And then you have your focal onset seizures. So these are your partial. Okay. Remember, occurring in an area of the brain that we can pinpoint. Okay. Focal onset awareness seizures. Simple partial used to be what we call them. These are seizures where a person is actually awake and alert. So they know what's going on. Okay, they do not lose consciousness, and that's another advantage of the focal or the partial seizures. Okay, they're easier to manage. The symptoms are not that severe. So with this type of seizure, the person is conscious. They understand what's going on. They may not be able to put it into words 100% of what's happening, but they are awake. They are conscious during the whole process. Okay, focal onset impaired awareness. So now this is a type of partial seizure. It used to be called complex partial seizure, and this person may have a little bit of confusion. They don't necessarily lose consciousness. Remember, generalized seizures, you lose consciousness. For focal, we just look at the awareness. Are you aware what's happening to you, or are you not aware? So with the complex partial seizures, these individuals, although they are typically awake, they're not sure of what's happening. And after the fact, you may have to, explain to them what just happened. And then you have your idiopathic seizure activity. Idiopathic, so if you see something testing and you see the word idiopathic, that simply means no known origin. Okay, obviously it started from somewhere. Something had to happen. We're just not able to tell what that is. So if you see something that says idiopathic or etiology unknown, we're pretty much saying we acknowledge that this is happening. We just don't know why it happened. We don't know where it came from. We don't know what caused it, what stimulated it. We have no idea. We're completely in the dark, but we do acknowledge we have this activity going on. Okay, so those are your 3 different types of seizures. Now you have epilepsy, okay? Because people always want to know, how do I know this is epilepsy versus, an isolated seizure event? So with epilepsy, you have to have one big factor or one big criteria for the diagnosis to be made, okay? 2 or more unprovoked seizures 24 hours or more apart. So I'll say that again. In order to at least be in the consideration that you have epilepsy, the person has to have had 2 or more unprovoked seizures more than 24 hours apart. So what does that mean, unprovoked? When you say a cause, it makes sense. Okay, the person had a high fever. Anytime your fever goes above 103, you are at risk for having seizures. They're called febrile seizures. If you get struck in the head, blunt trauma to the head, you can have a seizure. So like if you fall, a kid gets hit in the head, they're playing a sport, they hit their heads pretty hard. That is provoked. Okay. So when we say unprovoked or convulsion, yes, when you say unprovoked, I have no idea what caused a seizure. Just totally out of the blue, totally unprovoked. Okay, so these individuals, 2 or more unprovoked seizures at least 24 hours apart. Okay. And then, of course, we have to do the EEGs and the other imaging testing to be sure and definitive. But at least you have that to start the diagnosis of possibly epilepsy. Okay. Epileptic seizure. So when you're having an epileptic seizure, if we were to look at the brain activity, and that's another thing to keep in mind, when you talk about diagnosing a seizure, it is diagnosed after the fact. And we'll talk about that as well. Seizures are not officially diagnosed in real time. Meaning, I am looking at this individual, they're having a typical tonic-clonic seizure, the activity, they're on the floor, convulsing, I'm seeing it, but you still cannot diagnose that as a seizure in real time. I know what I'm looking at, but NCLEX, definitively, the diagnosis is made after the fact. So these are your risk factors for your seizures. Okay, now remember, epilepsy is just a seizure disorder. It's all the same thing. It is all still a seizure. Okay, these are your risk factors. Your blood glucose, believe it or not. Hypo versus hyperglycemia. Either direction, you can have a risk for a seizure. Okay, sleep deprivation. It's the reason why we tell you to get so much sleep at night. It's a reason. Okay, oh, somebody's writing on it. It's fine. I see somebody named Tony. It's perfectly fine. Okay. Sleep deprivation can cause you to have a seizure. Okay. Stress. Listen, nursing students, preparing for your NCLEX. Okay. That's why I tell students, put yourself on a pace, on a plan. You pass the NCLEX, so you study all day, all night. Nothing wrong with that, but you have to space it out. You can't sit and just, overwhelm yourself. Your body is going to get, exhausted and give out. And then you have your stress related issues. Okay. Genetics. Epilepsy can run in families. Okay. Illnesses. There are certain illnesses that can increase your risk for strokes, seizures, especially if you have a condition, any type of neuro, again, cerebral vascular accident, all of that kind of falls under the umbrella of strokes and seizures. Alcohol abuse. Okay. A lot of times, if you ever paid attention, people who are abusing alcohol heavily could possibly have a risk for seizures. Tony is just writing away. Let me see what is this? Tony, whatever, I want you to know, whatever you're writing, I can see it. We can see it. Not of this. It's okay. You don't have to erase it. I just find it funny because I'm like, how is this happening? It must be a setting. You ain't have to erase it. I'll just let you know we can see it. Now you have your triggers for seizures. So you have your risk factors and then there's triggers. Okay. One of the things that we try to do when it comes to the education is teaching clients to recognize their triggers. Same thing we do when you're teaching a person that has asthma. There is something that could trigger the activity. Once you know yourself, you know your body, you know your triggers, you try to avoid them. Okay. Flashing lights. If you guys ever paid attention, there are certain TV shows. If you go to a concert, you go to, let's say, the youth fair, somewhere where there's a lot of rides, there will be a disclosure that you may see. And that's an important disclosure. Okay. Yes, computer games. There will be a disclosure. This, show you about to look at, this concert you about to attend, there's a lot of flashing lights. Okay. Those strobe lights, when you go into a club, flashing lights could trigger seizure activity. So you might tell an individual, listen, if you are the type, the strobe lights, those flashing lights, you could tell somebody, listen, if you are prone to seizures, okay, flashing lights could trigger them. Try to stay away from stuff like that. Okay, or at least wear protective, glasses that kind of limits the exposure that you have. Again, elevated body temps. Usually we see it above like 103. We start saying, okay, risk factors for seizures. Head injuries, whether it is accidental or, deliberate, like somebody hits you in the head in a fight, or somebody pushes you and you fall down some steps and you hit your head. Okay. Kids, when they fall, we know how kids are always risk for falls, the younger ones. If they fall and hit their head a particular type of way, you may see seizure activity. Fluctuations in hormones, believe it or not, can increase the risk for you having seizures. Yes, trauma of any type. Okay, electrolyte imbalances, definitely the sodiums, your sodium levels. And lastly, poor diet, believe it or not. Okay, poor diet. There is a growth spurts, hormones. A lot of times people have hormones issues, and that's why they're having a stroke. And we don't have no idea in the very beginning. You know, you start putting pieces together or you start ruling out other stuff, and then you come to the conclusion this is probably what's causing the seizure activity. And then we get, straighten the hormones out, and it's like seizure activity stops. Okay, poor diet. And we'll talk about ways to treat. Believe it or not, keto diet. For anyone who's having trouble maintaining seizures, okay, there is research that shows the keto diet, brain tumors. Listen, especially if the brain tumor is, interfering with electrical activity, you absolutely can have that. Okay. So, symptoms of seizures. Now, remember, a lot of it also depends on the type of seizure the person is having. It's not always the convulsions that we're used to seeing. Okay. Sometimes it could look like a stroke. Anytime you have a neuro issue, sometimes those signs and symptoms, they overlap. And it's like, okay, what am I looking at? So you can have the confusion, the blurt, the speech, the jarbled speech. You could have the muscle contractions, which is the convulsions that people are used to seeing. Sometimes people wander. You also have to keep in mind older people manifest things differently. So if you're expecting to see something manifest the same way across the age spans, then you probably are going to struggle with recognizing signs and symptoms. You have to keep that in the back of your mind. Kids manifest things a certain type of way. Young adults, middle adults, older adults. Okay. A lot of times
Excuse me. Would lip smacking be a part of a seizure?
that is absolutely a part of a seizure. Remember, involuntary movements, definitely seizures. Yes. And with lip smacking, you could see that in a lot of the neuro conditions like Parkinson's. Okay. Oh God, akathisia. You can see that. But yes, lip smacking can definitely be a seizure. Okay, facial twitching, lip smacking, you know, uh, tongue in and out, definitely could be seizure activity. The blank stares in terms of the absent seizures, and now the chewing. So that's probably what you're referring to. Chewing, lip smacking, tongue, blinking rapidly, all of those uncontrollable muscle movements. Okay. So, diagnosing a seizure. Now, remember what I said earlier. Okay. Even though I know a tonic clonic seizure when I see it, the convulsion type, in the eyes of the NCLEX, that's not enough to diagnose definitively. You have to run your scans after the fact to diagnose a seizure. So, an EEG is usually done after the activity, and the EEG will show the signs of the seizure when you analyze and look at the results. Okay. MRIs, these are scans where you know something is going on, but you may want to get a better look. I want to get a better look at the structure. I want to get a better look at this area of the brain. Your MRIs and your CT scans are the ones for that. A neurologist definitely will bring in neurologists. They are experts on neural health. They will help to make the definitive diagnosis that the client had a seizures. Blood tests, believe it or not, there are some blood tests that we can do, and sometimes the blood work helps to rule out things. So it's not to help diagnose, a lot of times just to make sure nothing else is causing seizure activity. So we can look at electrolyte imbalances and we can look at other things that are important. But again, sometimes the blood work is just there to help rule out. Okay. And then your x-rays or your radiologic type images. Okay. Sometimes x-rays are good. They help give you a better look or just give you another type of perspective. Okay. But the EEG, that would be the best definitive tool for diagnosing a seizure. So treating seizures always, okay, maybe some type of medication that is involved. Now for NCLEX testing, there's different types of anti-epileptic medications. What is the one thing? Okay, now this is education. If I have a client that's going to be taking an anti-seizure drug, it doesn't matter what the drug is, but they're going to be taking this drug. What is a very important piece of information that I have to make sure I teach my client when it comes to this medication that they're going to start taking? What you guys think that is? Pharmacology, going back to pharmacology.
Do not stop abruptly.
Yeah.
Do not stop abruptly. Absolutely. Once you start a seizure medication regime, okay, you do not stop it abruptly, meaning you don't wake up the next day, I don't like these side effects, I'm going to stop taking this medication. Do not do that. You have to teach the client, if by chance they want to stop, they have to be weaned. Okay, it is a process. You cannot stop taking anti-seizure drugs abruptly. You can have rebound activity. So instead, we wean them little by little. We reduce the dosage until they're completely off. Okay, and you know, drinking alcohol and all that good stuff. Yes.
Please, I also think it is not only the anti-seizures, all medications prescribed by the PHCP are not supposed to be stopped abruptly.
Well, that is true. I mean, especially now, that's a compliance thing. That's definite. You know, a lot of times people, their symptoms go away and they stop taking medication. Say like an infection, you know, your symptoms improve. You know, you've been taking medication for 7 days. You're supposed to take it for 10 days. And you feel better, so you stop. Definitely, in a sense, you should not stop any medication abruptly. But when it comes to seizures, you can have what we call rebound seizures, meaning the activity can come back just like that. And that's definitely a little more dangerous than, you know, I was taking an antibiotic and I stopped. A lot of times I make sure clients understand when you're taking an antibiotic, even if you feel better, that does not necessarily mean the infection is 100% gone. That is why we tell clients, even if you feel better, take your entire course of antibiotics as ordered. Okay. Medical devices. These are implanted devices. One of the most common is called a vagal nerve stimulator. Think of like a pacemaker. It's the same concept. Okay. The vagal nerve stimulator, when they recognize that seizure type activity, that electrical impulse abnormality, they will send like a little shock, stimulate the vagal nerve. That is an internal way to try to monitor or control seizure-like activity. So it's like it's like again, if you have like an internal pacemaker, it's the same concept, except this is for the brain managing seizures. Okay, surgery is an option that a lot of people don't think about. If you have focal seizures or partial, meaning it is one-sided, it is pinpointed to one area, there is a possibility that you can have surgery to remove that portion of the brain that is causing the seizure activity. Now, there's a lot of things that goes into the decision to do this. The risk shouldn't necessarily outweigh the benefit, meaning, is this focal seizure in an area of the brain that if I take this part of the brain out, is it going to affect the quality of life for this client? That is something that we have to consider. It's very easy to cut out a portion of the brain. I mean, this is where the activity is right here in this one spot. Let's cut this out. But again, if it is going to alter the client's way of life, meaning their functionality, the ability to do ADLs, you know, will they become a shell, you know, unresponsive, not able to talk, immobile? If that is the risk because of where this seizure is actually occurring, then surgery comes off the table. Okay, you can manage partial seizures. I mean, it's nice to kind of get rid of them if we could, but again, based on the area of the brain that is affected, sometimes surgery is not an option. Okay, diet, keto diet. Okay, there is a scientific link between keto diet and what is the keto diet? What are you trying to do? You're trying to send the body into what? Ketosis. Okay, and how do you do that? So you're cutting what out or cutting back significantly when you're on the keto diet? What you're reducing? What type of food? Sugary, carbs. Okay, when you're on the keto diet. Okay, and when you reduce your carbs significantly, your body goes into a state of ketosis, and when you are in a state of ketosis, you burn fat. That is why For a lot of times, diabetics, when they have uncontrolled diabetes and their sugars are abnormally high, they're extremely hyperglycemic. A lot of people with diabetes, they lose weight. They're not realizing why they are losing weight, fat and carbs. They're not realizing why, but they're losing weight despite not trying to. It's not like they're on a diet trying to lose weight. They just lose weight because, again, their blood glucose is uncontrolled. And then rehabilitation, remember, in the aftermath, the activity has happened. If the client has a massive type activity and they need some rehabilitation, again, is this going to be in the home rehab, or do they need to go to a facility for a certain amount of time so they can get the therapy that they need so that they can go home? So nursing management of a seizure, always important testing material. Priority. NCLEX love a priority question. What do you do first? What is my priority? What is the most important thing I got to keep in track? Safety. That is your priority when a person is having a seizure. Safety, safety, safety. You have to protect your client as the nurse. Okay, if I am with a client and I know they have seizures and I recognize seizure activity, the first thing that I will need to do is make sure if my client is standing, that I safely get them to the floor. Please don't let nobody drop to the floor, because if they hit their head, now you got a whole nother issue. But my goal is to safely get my client to the floor. Now, if they're in bed, you don't have to move them out the bed. You just take care of them in the bed. But if they are walking and they start the seizure activity, help guide them to the floor. They can slide against your body to the floor. They can slide down the wall. You just don't let them drop. Okay. Hopefully, if you're able to, you can time the seizure. A lot of times doctors like to know stuff like that. That helps them with prescribing medications. Because sometimes you'll have an order for a medication and it'll say, give if seizure lasts longer than 10 minutes. So sometimes you have to be able to time the activity to help the doctor with diagnosing or prescribing certain treatments. Okay. It is okay to loosen restrictive clothing. If the client has their shirt buttoned up to the neck, if they have any restrictive clothing, for example, they have the, around their wrist is buttoned, it is okay to loosen restrictive clothing. A lot of times with that seizure activity, if the clothes are restrictive, it can compromise the airway or other things. So yes, you can, loosen restrictive clothing. You can do that. You cannot restrain activity. If a person is having convulsions, you let them have convulsions. All you do is you clear their area. If it's a loose table on the floor, push it out the way. If it's a chair, push it out the way. If it's a bed, hopefully you can unlock it, push it. You want to clear as much space around the client as you possibly can to reduce the risk of them injuring themselves. That's where the safety comes in. You can put a pillow under their head to reduce the risk of their head banging onto the floor. Okay. Never stick anything in a person's mouth when they're having a seizure. Never. Your concern when it comes to safety is the risk for aspiration. Okay. If you put something in somebody's mouth when they're having a seizure, they can aspirate. Worst case scenario, do not stick your finger in nobody's mouth when they're having a seizure, unless you want to lose that finger. One of the things that they compared the strength when a person is having that tonic-clonic seizure and they clench the jaw, they have compared that to the pressure or the strength it takes. Like if a person is in a really, really bad car accident and the car is like mangled, they got to use the jaws of life to kind of cut people out the car. Science have compared the pressure and the strength a clenched jaw has during a seizure is the same that you see having to use the jaws of life to cut somebody out of a mangled car. So I tell my students, unless you want to lose your finger, you definitely don't put your finger in nobody's mouth. No tongue blades, no fingers. There's no such thing as swallowing the tongue. I know some of y'all have heard that. Honestly, I don't even know where that came from. Where did that whole, they can swallow their tongue? That's not a real thing. Okay. Because what if you do manage to pull their tongue out their mouth? Or, what if they bite down? Now they didn't bit their own tongue off. So you don't have to stick anything in their mouth. You don't have to worry about them swallowing their tongue. You do have to worry about aspiration, but it is not going to be from swallowing their own tongue. Okay. Once the seizure activity has subsided, okay, the activity is starting to calm down, the client is starting to, they probably will go into that post-seizure sleep. You can roll them to the left side. Okay. Rolling, a lot of times students, what's the difference between rolling to the left, rolling to the right? The liver. I mean, it's not really, listen, to the side. If you just had to choose, roll over to the side. If it is an option, the left side is preferred over the right side for recovery. This also reduces the risk for aspiration. That's the worst case scenario. Someone aspirates while they're having a seizure. So turning them to the side is definitely something that's going to help reduce the risk. Now, if they're having a lot of convulsions, you cannot force them onto the side and hold them down. Remember, we do not restrict movement. Only when the seizure activity has started to stop and they are going into that post-seizure sleep, then you can safely turn to the left side. Okay?
Question.
Yes.
Okay, so if you saw a question on NCLEX pertaining to turning to the left, and it says also turn to the right, what should you choose? Because since it's
Left.
both sides can
The
be
left.
done.
The left. Sometimes the NCLEX is not going to be that, what's the word I'm looking for? That, specific. We prefer the left side because again, it's just about a position of recovery. Honestly, if it's easier to turn the client to the right side, you're trying to reduce aspiration. Honestly, whether they're laying on their right side or their left side, turning them to the side reduces aspiration risk. We prefer the left side. And you also see this in maternity. When you're turning a mom to the side, if you have an option, the left side. Again, the liver. When you lay a person on the right side, you're putting more pressure on the liver.
Pressure
Now,
on the liver. Yes.
if it's not a lot of pressure, it's not like, oh my God, they're laying on their right side. This is not good. It's not that serious. It's just in terms of anatomy, the left is preferred over the right. That's it.
Okay.
But sometimes they're not even gonna ask you. They're just say reposition, turn to the side. But if there is an option, we do choose the left over the right. Okay. Try to stay with the client until the seizure activity has subsided. Again, safety, do not leave the client alone. Once they are stable, then you can leave and call the physician or try to get somebody else to call the physician for you. Any questions with seizures? Any questions?
I have a question about the medication. Is
Okay.
that lorazepam that they give to the seizure patients? Benzo?
Yes. The lorazepam, the benzodiazepines, lorazepams, dilatin, all of those are seizure drugs. Yes.
Okay, thank you.
And you have to, especially with children, they have to be weighed. A lot of those are weight based. A lot of those have, risk for toxicity. So you have to have levels drawn. A lot of that comes with the education with the clients. You have to have levels drawn to make sure you have the right dose, that you're not toxic. So yes, those are your typical seizure drugs. Yes. And
Okay,
go, no alcohol, while taking meds, the typical pharmacology stuff. Okay, so it is 10:35, you guys. Let's take another 10-minute breather. Okay, we're going to take a 10-minute breather, and then we are going to get into traumatic brain injuries, increased intracranial pressure, and then we'll go into our NCLEX questions.
I have a question. I didn't get the clearly the difference between epilepsy and epileptic seizures.
Oh, they're the same thing. Epileptic, epilepsy, those are the same thing.
Okay.
Okay, remember, it's just 2 or more unprovoked seizures at least 24 hours apart.
Okay.
Okay,
Thanks.
you're welcome. Oh, Tony did post, right? That's also an answer. Remember, it's reducing aspiration risk. Okay. Honestly, rolling to the right side, do the same thing. Now, if they've eaten, see, the thing is, the NCLEX, so you're not supposed to assume everything. Thank you for posting that, Tony. You're not supposed to assume anything. Like, I don't know if the client ate. I don't know if the client didn't eat. I don't know anything. I just know that my client is having a seizure or what looks to appear to be a seizure. And if you can, yes, rolling to the side does prevent aspiration because you're trying to protect the airway. So rolling to the side does that. Again, if you have a preference, yes, rolling to the left is, of course, preferred. But again, I have no idea if my client ate or not, because they could have not eaten and I'm still want to protect the airway. So yes, that is another option outside of pressure on the liver is not, pressure on the stomach as well. Thank you for that, Tony. Thank you. So 10:45. We'll be back. You guys, I'm going to be checking on something while we're on break. So I'm going to briefly stop sharing, but then we'll come right back to this page when we start back at 10:45. Let's go ahead and finish out so we can get into our NCLEX questions and end for the evening. Okay, let me make sure we are recording because I did pause it. Okay, we are recording. Good, good, good. So last for tonight will be traumatic brain injuries and increased intracranial pressure. Now, before we get started, do know that increased intracranial pressure is not a condition itself. Increased intracranial pressure is the result of something else. If you treat that underlying something else, you can manage increased intracranial pressure. Okay, so what is a traumatic brain injury? You can have a traumatic brain injury when there's some type of physical trauma to the head or some type of an injury caused by another force. So you have a primary injury. Primary is direct trauma or vascular structures, direct trauma to those areas. Okay, so getting struck in the head, direct access, let's say that there's a vascular accident and there's a hemorrhaging, because you always think blunt force trauma. See, the trauma is not always caused by blunt force. Okay, trauma is a very general term, but there's some type of a traumatic injury primary right to the structure itself. Okay, an aneurysm, something, that's also traumatic primary injury. Then you can have your secondary. Secondary is ongoing. Okay, little by little there's injury. Okay, like for example, over time oxygenation is decreasing. Okay, that could be a secondary. It's not all at one time, like again an aneurysm rupturing, but over time there's damage, little by little to the brain until you have the actual traumatic injury that's causing some type of an effect. Okay, so these are your risk factors for traumatic brain injuries. Okay. With people, you have to do a lot of education just to protect themselves. A lot of times we see traumatic injuries and we say to ourselves, this could have been avoided. This could have been prevented. If you're playing a sport, wear the right protective equipment. I don't understand why anybody would play baseball and not wear a protective helmet when you have fastballs flying at your face, right? Or if you are riding a skateboard, wear a helmet, wear elbow pads, protect yourself. If you're riding in a car, wear your seatbelt. Okay. Try not to do something risk-taking, drinking and driving. Okay. Risk factors, prevention, probably one of the best ways to reduce the risk for experiencing a traumatic brain activity. Submersion injuries, believe it or not, drownings, that would be a submergent injury. So when you say something gets submerged, you're not, your nose, your mouth is underwater. A lot of times you think big body of water when you say a submergent injury, but think about it. As long as your mouth and your face is submerged, that is a submersion. So if you have a small child, this is just an example, like a baby in a bathtub, and you turn your back, to do something, and the baby rolls over and falls face down into the water and they can't lift their head up, that is a submergent injury. Okay, older people, falls, you always want to consider what are my risk factors. And a lot of times we look at the age, and that's just a normal part of aging. It's not that, they had a stroke, so they're, not good on their feet, or dementia, they don't walk well, Parkinson's, they don't walk well. It could just be a natural thing when it comes to aging, when it comes to an older person's risk for falls. The best thing to prevent is to educate. Okay, if you are at risk for traumatic injury because of your age, developmental ability, disabilities, the best thing is just to educate. Okay, to help reduce the risk of experiencing a traumatic injury. These are your manifestations of traumatic brain injuries. Okay, sometimes the signs are very subtle, meaning you might see a sign, but you don't know that's what it's caused by. You might think it's something else going on. But at the end of the day, when we do our health and our history, we kind of lead up to the diagnosis of a traumatic brain injury. Altered levels of consciousness, being very fatigued, sleepy, confusion, memory loss, such as a concussion. A concussion is a type of traumatic brain injury. Okay. Sometimes the symptoms don't last for an extended period of time. So you don't think it's not permanent. It is still a brain injury at the end of the day. A person who mood suddenly changes. 1 minute you awake and you alert. The next minute you're agitated, you're confused, you're combative. It's like your whole mood just changed suddenly out of the blue. Okay. Headaches. anytime a person hits their head, no matter how they hit their head, you have to consider, is there a possibility of a traumatic brain injury? One of the stories that I like to tell students, if you guys ever saw the movie Parent Trap, and that's one of my favorite movies, the one with Lindsay Lohan, where she played the twins herself, the mother in that movie, Natasha Richardson, she was in a skiing accident and she ran into a tree skiing, on vacation. And the people at the resort tried to get her to go to the hospital, just to be safe, just check yourself out, make sure everything goes okay. She was refusing. I'm feel good. I'm fine. I don't need to go. I don't need to go. They kept trying to insist for her to go. I want to say 2 or 3 hours later or something like that, she started complaining of a headache or her head was hurting, something. Finally went to the hospital. Unfortunately, by that time, it was too late. She experienced a traumatic brain injury that turned into a full hemorrhage. The problem is, had she went to the hospital when she first had the injury, they could have caught it early. And then, of course, they probably could have saved her life. So anytime I have a client that hits their head, I tell them, you know what? Be safe rather than sorry. If you don't want to rush to the, right away, pay attention to the signs. You can't make nobody go to the hospital. You can't make nobody go to the ER. At least you can educate them. Just pay attention to the signs. I tell a parent, do not let your kid go to sleep after hitting their head. Okay, keep them up for about 6-7 hours and just monitor their activity, monitor their levels of consciousness. If they show signs that their neural functioning is declining, rush them to the hospital if you can. Not everybody wants to run to the hospital, So in a perfect world, everybody just run to the hospital. The Parents Trap, yeah, that was, listen, I love that movie so much. Diagnosing traumatic brain injury. So it's not that complicated. You have your imaging studies, CT scans, MRIs, functioning exams. That is just to see the level of injury. Is the person functionable? Okay, depending on the severity, they might lose their ability to ADLs and things like that. Therapeutic evaluation. You need to bring in a specialist, a neurologist, of course, to help with the diagnoses. And lastly, of course, an EEG. One of the most common questions, what type of injury am I looking at? How bad is the brain affected? If there's still some electrical activity, if there's no electrical activity, then are we going to declare this client brain dead, or are we going to try something else? Okay, because parents, especially parents, spouses, after someone has a traumatic head injury, what's going to happen? Are they going to be okay? Unfortunately, at that moment, we have no clue. We have to do our imaging studies. We have to do an EEG. I don't want to tell somebody your people going to be okay and they're not. Okay, a better therapeutic answer is to say, okay, we don't have an answer for you right now, but we're doing everything that we can, something like that. You're not giving false hope, but you're also validating the client's concerns as well. So treating traumatic brain injuries totally depends on the injury itself. If it is a mild injury, the kid fell and bumped their head, they got a little hickey, a little bruise, they call in and say, hey, my kid hit their head, I'm concerned, they have a little bruise or a little swelling. I'm gonna ask you questions. Are there any bleeding? Do they seem very irritable? I mean, of course they're crying, it hurts, but your kid, are they just really, really irritable? Or if they're an older kid or an older person, are they complaining of headache? Are they complaining of photosensitivity, meaning the light is too bright to them? If there's things like that, you probably need to bring them in, of course. But if it's nothing like that, okay, just watch them over the next couple of hours. Do not let them go to sleep, type thing. Severe trauma, they need to be brought in. Point blank, period. We need to do imaging studies, like in the case of Natasha Richardson. What if they have a very small brain bleed? At the moment, I don't see the brain bleed. I don't see symptoms of a brain bleed. But as it gets more and more time and the brain bleed gets worse and worse and worse, now I'm starting to see symptoms. Best case scenario, I should have caught it when it was a minor issue and there was no signs of symptoms to reverse the possibility of irreversible brain damage. Okay. Rehabilitation, a lot of people need it after a traumatic injury. Okay. PT, speech, OT. Okay. Any type of therapy to help return a client to their functioning self or as close to their ability to function on their own as possible. Then we get into increased intracranial pressure. Okay. Now, remember what I said. This is not a condition by itself. This is normally caused by something. Traumatic brain injury, for example, submergent injuries, for example, a concussion, for example. This is where the pressure around the brain increases. Okay. Your brain is a free floating organ. It is not attached to anything. It does not adhere to anything. It is basically sitting inside of your skull, floating. Okay. It is covered by cerebrospinal fluid as a protective mechanism. Anytime there's a buildup of cerebrospinal fluid, a buildup of blood from, let's say, a brain bleed, anything that causes a buildup of fluid around your brain, that is going to cause the pressure around the brain to increase. That cerebrospinal fluid, that blood that sits around the brain, it causes pressure. And the more fluid you have built up, the more pressure is going to be exerted around your brain. The problem is your brain can only withstand so much pressure. So when it comes to increased intracranial pressure, I need to be able to catch it right away, because if I don't relieve that pressure, however I'm relieving it, if I don't do it, there's a chance that my client can suffer irreversible brain damage. Okay. So these are your manifestations of increased intracranial pressure. Now, these are signs that are divided into two types. You have early manifestations, and then you have late manifestations. Early manifestations are very vague, meaning I could see the signs and symptoms, but I could be thinking of something else. For example, nausea and vomiting. You would first think GI. If I have a client complaining of nausea and vomiting, I'm going to think a GI issue before I think, increased intracranial pressure. Slight change in consciousness. Okay, I might just think, are you sleepy? You need a nap, something like that. Or if it's a baby that's irritable, crying a lot, maybe they need a nap, maybe they're hungry. It's very subtle. So I might miss it. Okay. Headache is very, very common in the early stages of increased intracranial pressure. And then you start having the signs and symptoms where this has been going on for a while, and now it has gotten worse. Now we start talking about the eyes, for example. When I flash a light into your eye, what should your eye do? You guys, if I was to shine a light into your eye, what happens to your pupil?
Dilated people.
It constricts. Okay, that is a good way to assess brain functioning, especially if you have a client that's unconscious, because I still have to do a neuro assessment whether you are conscious or not. So how does your eye reflect to the light? If your eye doesn't constrict when we shine a light in it, that's a late sign. Okay. If you have seizures, you start having seizures, that is a late sign. Okay. Changes in your speech patterns, late signs. Okay. Another thing we look at, motor functioning, late sign. There is something called sunsetting eyes. Okay, this is a huge late sign of increased intracranial pressure. When you look at someone in their eye, okay, you only see the white part of the eye, okay? Where you see the white part on the sides, you only see the white parts there. Think of the sun setting. Okay, when the sun sets, it goes down. Think of your eyes doing the same thing, sun setting eyes. So your eyes cast downward. Okay, and I see a lot of the white parts over your eye. Those are called sunsetting eyes. That is a late sign of increased intracranial pressure. So for testing, not only do you need to know what the signs of increased intracranial pressures are, but is this an early subtle sign, or if this is a sign that this has been going on for a while and the signs are getting worse. Okay. Posturing is another big sign for increased intracranial pressure. Now, when a person assumes a posture such as what you're looking at, this is not a good sign. Okay, this is a sign of brain injury. Posturing. A lot of times, if someone gets struck in the head, and I know you guys have seen this before. Someone gets struck in the head, they fall to the floor, and their arms get stiff, some type of way. They posture. Okay, again, that is a sign of a brain injury. Now, both of these are not good. Okay, let's just say that now. Both of these indicate injury. However, there is one that is worse than the other in terms of injury. Okay, the corticate is less severe than the cerebrate. So the corticate is here at the top, the cerebrate is here at the bottom. Testing, you may be asked, describe the posture. So if the question asks you to describe the corticate posturing, you have to put it into words, or describe the cerebrate posturing. You have to put it into words, or they will describe the posture and you have to name it. Okay. One of the ways that I teach students how to remember which one is which, the easiest thing to remember is decerebrate. Okay. What we come up with is when you say decerebrate, it almost sounds like celebration. Decerebrate, celebration. When a person is celebrating, your arms typically, yeah, your arms go out. That is what happens when you have decerebrate posturing. The arms are out, stiff at the side. If I was to look at decorticate posturing here at the top, the arms are close to the core. So you have students that remembers the decorticate core, arms to the core. As you can see in both pictures, the legs are similar. Okay, legs are straight, toes are pointed. It's usually the arms that helps you to determine what type of posture I'm looking at. So again, decorticate core, arms are to the core, tight. Decerebrate, okay, the arms are out like you're celebrating. Okay, again, both of these indicate injury. It's just one is a more serious brain injury, and that is decerebrate. Okay. So treating increased intracranial pressure, remember, if you find the underlying cause and you treat that, the increased intracranial pressure is going to lighten up. So if it's a brain bleed, blood is building up around the brain, pressure around the brain is building up, I need to stop that brain bleed. Okay. If it's cerebrospinal fluid buildup, you see that more in kids. I need to relieve that fluid building up or swelling. That is perfect. Yeah, that's how I taught my students. It's easier. Listen, that's how you learn stuff and you retain stuff. Sometimes you got to make up, like I said, an acronym or some type of way. Because listen, this is a lot of information y'all learning. You can't remember everything. So sometimes, you just give yourself a little cheat sheet. That's it. So again, once you reduce the swelling or the buildup, the pressure should start reducing. So one of the easiest ways to do that is a drug called mannitol. Okay. Anytime you have increased intracranial pressure and the nurse should suspect or expect a medication, mannitol is always at the top of the list. Mannitol is an osmotic type medication. It is going to pull fluid out. Quickest way to start relieving pressure around the brain, pull fluid out, mannitol is given via IV. Okay. Or you may see the client be ordered a hypertonic IV solution. Okay. Remember, if you go back to fundamentals and you talk about cells put inside solutions, what happens to the cell? Okay. With isotonic solutions like regular normal saline, nothing happens to the cell when I put the fluid, the cell inside the fluid. With a hypertonic, if I put a cell inside of a hypertonic solution, the cell is going to shrink. Why? Because it is pulling fluid out. That is why you may see a hypertonic solution ordered for a client that has fluid buildup. Which one assigned? Patient progress. So if the patient starts progressing, then they're not posturing as much. Okay, so that's how you know a client is getting better. The signs start to disappear. That's a great question. If I was concerned if my treatment is working, is the client getting better neurologically? Okay, if they are declining, they're not getting better. But if they're, they're not posturing. Glasgow Coma Scale, definitely if you have an unconscious patient, because even if an unconscious person has a brain injury, you still have to some way you have to, assess them. Okay. Sometimes they have to do a craniotomy, cut parts of the skull away to give room for the brain to grow if it has swelling. Deep tendon reflexes, all of those. Yes. And remember, you got to be real careful with your neural assessments because we don't want to aggravate the client either. Aggravation can make the pressure go up, believe it or not. We do our assessments, we do vitals, we do neuro assessments, but we don't, we do it as often as we have to. Some places they want you to do it very often in the beginning, so you catch if the client, declines. But after a while, once the client is more stable, you don't have to do them as much. We don't want to irritate this person no more than we already have, because crying and irritation can also make the pressure go up. Let me see. Constipation can cause intracranial pressure. That's something I left off. Osmotic diuretics, mannitol, steroids. Yes, exactly. Because you have to think pulling fluids out. Constipation can increase pressure. So of course we want to keep the client, hydrated, diet full of fiber. Let me see. Anything else that I miss when it comes to treatment? Peds, if you go into pediatrics, they do certain things for kids, like if they have hydrocephalus, which is a lot of fluid buildup around the brain. Remember, when the pressure starts to subside, the client signs gets better. That is how you evaluate the effectiveness of your treatment. NCLEX was going to ask you that. How do you know what you're doing is working? Because we don't just do interventions and walk away. We do interventions and we evaluate effectiveness. So how do I know my client's intracranial pressure is getting better? Their neuro status is improving. You can always directly monitor pressure around the brain. Yes, there is direct monitoring. But if we're not there yet, there is no direct monitoring, I need to do neural assessments. Or they put part of the skull in the app. They absolutely do that also. The whole point is to give the brain room to swell. Because remember, your skull encapsulates, keeps your brain in a capsule. If your brain has swelling and your brain has nowhere to grow, that could be damaged. So sometimes they cut a piece of the skull away to give your brain room to swell before the swelling starts to go down. Okay. If your signs of increased intracranial pressure come back, that means your client is declining again. Okay, so nursing management, these are your responsibilities. Monitor neural status. Whether your client is unconscious or not, you have to keep an eye on them neuro-wise. Remember, 1 minute they're awake, they are alert. The next minute, confusion, agitation, combativeness, or they become unconscious altogether. That is a sign of decline. And the quicker you catch it, the quicker you can act and work on your client.
Should also
Evaluate.
should
Go
also
ahead.
teach should also tell the patient not to cough or strain or
That's why I said, yep, straining, constipation, stuff like that. Absolutely. Anything like that can cause the pressure to raise. Posture, in terms of bed positioning, that's another one. If I have a client that has intracranial pressure issues, I'm not going to lay them flat. Laying someone flat can cause the pressure to increase. I'm also not going to put the head of the bed too high. Believe it or not, putting the head too high can cause the pressure to increase. So it's like, okay, where do I put the head of the bed? Okay, no higher than 30 degrees. Well, semi-filers, even 45 is a little high. In the beginning, low semi-filer, so 30 degrees is kind of because again, we don't want it too high, but we don't want it too low. So around 30 degrees is more what we consider suitable. They're not too flat, they're not too high on either. Because you have to
what
kind of
about 10? What about 10?
10 is still a little low. Remember, if they're laying flat, they're about 15 to 30 degrees is considered adequate. Okay. That's most literature says 15 to 30, no higher than 30. Most literature does support no higher than 30. Complaints. So again, complications, if the client is saying that, the lights are bright or my head hurting or my vision's getting blurred, or again, they're showing signs of complications, neural status is getting worse. Your job is to catch that. So your job is to monitor. Okay. And always review the risk factors. Remember, increased intracranial pressure is not a condition by itself. It is typically called runny nose and blowing your nose. Absolutely. Okay. If I can, I'm going to try to prevent them from blowing their nose. That can definitely raise the intracranial pressure. Okay.
Can you
Going
get
over risk factors. Go ahead.
can you get cushion triad from it too?
Yes, you absolutely can. That is very advanced, but you can get the Cushing's triad. As a matter of fact, let me go back right quick because the slide that I put, here it is right here. Cushing's triad. Okay. Cushing's triad is a very late sign of increased intracranial pressure that has been there for a while and has not subsided. So when we talk about your early versus late sign, Cushing's triad will fall under the late sign. So for anybody that's wondering, it's a trio of vital signs. Okay. Your systolic BP shoots up, pulse drops, and there's an alteration or change in breathing patterns. Okay. Normally we say it doesn't matter what direction your vitals. If your vitals change from the baseline, that's a red flag. But for Cushing's triad, it is a specific change we look at. Again, systolic BP increases, pulse decreases, and then there's alterations in breathing pattern. That is called Cushing's triad, and it is a vital sign change. Okay.
But
So if you
for
go
the
back, go ahead.
infant, can they also Different from the bulging fontanelle. Can they get like strabismus or?
They can. So I didn't talk about because that's peds, but in the case of infants, absolutely. Bulging fontanelles, altered levels of consciousness, irritability, listen, all of that. Yes, in babies, absolutely. Kindly repeat early versus late sign. No problem. So your early signs are very subtle. Okay. Nausea and vomiting, headache, blurred vision. You might see some photophobia, which is light sensitivity. Those are very subtle. Okay. I might not catch this is increased intracranial pressure right away. CPP. For some reason, I'm drawing a blank, and I'm pretty sure I know what that is. I'm just drawing the blank right now. So, Andy, could you type that out? Watch, I know what this is. Cerebral perfusion could be okay, or in terms of cerebral edema, you can look at it that way. Definitely will increase the intracranial pressure. Um, so again, signs are very subtle in the beginning. You might think it's something else, like especially if I see nausea and vomiting, or a better way to look at it, if a kid is crying or a person is crying and they get choked up and they vomit, that makes sense. Okay. But if a person out of the blue, they don't have no GI issues, no food poisoning, they haven't overeaten, why is this person just vomiting out of the blue? Red flag, early signs of increased intracranial pressure. And then the late signs are those that you see because the pressure has been there for so long. Now the brain is suffering damage. So seizures, definite altered levels of consciousness, comatose, um, what else, the sunsetting eyes, loss of motor functioning, the eyes, perla, the Glasgow coma scale score is very low. Perla is not good. Your eyes don't constrict when the light, those are your later signs. And again, when you get into the later signs, it's been there for a while. The hope is that there's no irreversible brain damage.
Would you, for late sign, would you have like the widening pulse pressure for the late sign or early sign?
Widening post pressure, that is a very advanced sign, but yes,
Okay, that's
you
late.
can't have the widening post pressure. Look at y'all. That's advanced monitoring. Okay. But yes, you can't have the widened post pressure. Okay.
That's the Cushing's triad, the high BP, widening pulse, and then the bound pulse. Those are
It'll
the
be
three things
it'll
that
be
make the Cushing's triad.
So for Cushing's triad, it's elevated systolic. So that's the top number. Elevated systolic, a decrease in pulse. So from the baseline, a decrease, and then there's just an alteration in breathing pattern. So you had a baseline breathing pattern, and then it changed.
Yeah, the white pulse and the shiny stroke and the bradycardia and stuff like that.
Yes. So that's pretty much what you see with Cushing's triad.
Yes.
Okay. So let's get into our questions. That was good, you guys. I like when it's the conversation and you guys add your input. That shows that you're following and that shows that you know what you're talking about. I like that. Okay, so let me exit out this first. Okay, so I'm going to share my screen one more time, and these will be your NCLEX questions. So you guys should be able to see the screen. So what I want you guys to do, okay, go ahead. You can type in the chat your answers, or you can always unmute and, add your input. So 10 questions related to stroke, seizures, and increased intracranial pressure, including traumatic brain injury. So both of those together. So question number 1. A nurse working on a neurological floor has received reports on 4 clients. After identifying priority assessment data for each client, which client should the nurse investigate first? So when answering priority questions, keep in mind, okay, you are not saying that the other options are not important. Everybody needs to be seen, okay, especially when you have clients on the floor. Everybody needs the nurse. However, who do I see first? This person cannot wait.
A.
They can get worse, stuff like that. So majority I see A. Okay, A's, 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 and the correct answer is Oh, did somebody take over? Hold on. So give me a second. Somebody has taken over the screen. Let me see. Let me see if I can recover this back. Give me a sec.
No, you are the host.
There we go. Okay. My computer must have froze a little bit. That's what it was. I saw somebody writing across the screen and did I lose control of it? On my end, it did freeze. So the answer is A. Do y'all see that little red line going across the screen? Do y'all see that? Or it's just me?
Yes, the
Okay.
red line.
So right after that line showed up, my computer froze. So the correct answer is A. Good job. Okay. So your client who is experiencing nausea, remember that is an early sign of increased intracranial pressure. Okay. I'm going to go back to the answer options right quick. Post-stroke client. Now, when it comes to these types of questions, sometimes you get caught up in the diagnosis. Okay. B is a stroke person. That is important. However, look at the client status. They are ready to go home. Okay. They are not a priority. They just waiting to go home. So that means they're stable. That's not who you need to see first. Okay. Client that is following a procedure, a loose dressing, not an emergency. I can probably even, delegate that to an LPN. And then D, okay, 2-year history of paraplegia, UTI. Of course, I want to get to the infection quickly. However, none of these clients take precedence over a client hit their head and now has nausea. That is a sign of a brain injury. That could be the beginning signs of increased intracranial pressure. Question number 2. A client admitted to the unit has been started on warfarin to reduce the risk of a stroke. What should the nurse instruct the client to do when taking this medication? Select all that apply. So warfarin is an anti-clotting medication, places the client at risk for hemorrhaging. So if I need to provide education to my client, what would I instruct them? Is post-anxiety,
A,
possibly.
A, B,
Mm-hmm.
D.
So I have A, B, and D.
Yep, so far.
Okay, so I have A, B, D. Who else? I see A, B, A, B, C, A, B's.
Maybe.
Okay, it seems like we all are.
Oh, floss the teeth deep into the cereal.
Okay, now you
Sorry,
caught
sorry.
that. That's
I
why
didn't read
I
it
was gonna
properly.
wait.
Sorry.
I was gonna wait to see if you caught that.
Yes,
Listen,
sorry. Do not
that's one
floss.
of the things.
Yes.
Listen, that's one of the things we do on our test. We do not read thoroughly. You gotta read and you gotta catch that.
Just saw
That
it.
was the clue. Deep. Remember, this client is a bleeding risk.
Yes.
Correct answer is ABC. Okay, so for a lot of people who put D is not correct because I'm gonna go back. D says floss deep into the gums. Remember, you are bleeding risk.
You can't.
Okay.
Right.
If you floss too deep, you can start hemorrhaging. So I would not tell my client to floss deep. Yes, it is important to take care of your teeth. Let's talk about it. But flossing deep, probably not a good idea because you're a bleeding risk. Okay. And taking a medication, avoiding below 60, that is the Joxin. We do not. The pulse is not a factor for administering warfarin. Okay. Why is it C? Oh, that's a good. Oh, somebody asked a question. So let me see if one of you can answer it. So one of your classmates asked the question in the chat. Why is C the answer? So somebody, Andy, put blood. Be more specific. What about blood in
Yeah,
the urine?
that could be hematuria.
Mm-hmm.
That is blood
Hematuria.
in urine.
Yes.
Yeah.
So
So
what color would your urine change if
that
you
would
have
be bloody. Red.
Like
not red? That's a
Yeah, bloody.
misconception.
That's red color, bloody.
It'll
Probably
be
can have
dark.
bleeding going on.
like cola.
Dark color. So think tea color. Tea. Like iced tea. The darker your urine is, the more blood is in it. So if you have like, let's say like a light brown, that's hematuria, but it's not a lot of blood. Now, if your urine looks like Coca-Cola, Okay, dark brown, that means you have a lot of blood in the urine. So, me telling the client to report change in urine color, that's me pretty much saying amber color. That's me saying if you have bleeding into the urine, it will turn a dark color. You need to report that. So, that's why C is the answer. Okay, it's
I
called
got I got
hematuria.
a question. On a NCLEX examination, they will ask you to select that answer because it is not specific to what type of change you're
It's
looking for.
not.
Oh,
But it just see now sometimes we can overthink stuff and it kind of this is just saying report any change. Remember your urine color, if your urine changes color, it could be an infection, it could be blood, but when it comes to urine, okay? Now yes, they could have been more specific and they could have gave a color, but still it's a color change. If your urine is normally a pale color and all of a sudden it's a tea colored and you're taking a blood thinning medication, that's important for you to report. That means you're experiencing hematuria, which
that's why
can
you need
happen.
it. That's why you need a PT-INR.
And that's why we need to make sure and see what's going on. Can you please take this mark? Please take this mark. What does that mean, Joanna? Take this mark for the question for number 2. I'm not sure what that means. You could type it in the chat. A red mark. Oh, I'm not sure how to get this off. Let me see. Somebody put this on, whoever put that on there. I'm not able. I'm sorry. I'm not sure how this. It's like the person went to annotate. Let me see if I can. Oh, there it is. Perfect. Yes, normal urine could be anywhere from a light straw color. If it's too dark, you could be dehydrated. But yes, urine does. If urine is too light, that could be a bad thing. Also, you're probably drinking too much water. So kind of like a yellowish, amber color is a good sign. Question number 3. A client has a seizure while a nurse is performing a bed bath. Which of the following are priority actions for the nurse to implement? Remember, priority doesn't mean everything is not important. Priority simply means what should I do right away? So select all that apply. I see a lot of A, B's, and D's. So time the length of the seizure,
B,
observe the stages of the
A,
seizure,
D,
turn the client.
And
That is
ABD.
exactly
and
correct.
the
ABD. Okay. So just to go back, do not place anything in the client's mouth. We talked about that. They can clamp down, risk for aspiration. You could lose a finger. If you pull a tongue out, they can bite their own tongue off. So we do not put anything in the mouth. No need for a tongue depressor or anything like that. Sideline, we talked about the benefits of that. We said liver, we said risk for aspiration. If the client has eaten, it can definitely reduce the risk for stomach contents coming back up. So that is why we do prefer the left side over the right. But if the answer just says turn to the side, side lying, that's just indicating left or right. Okay. Question number 4. After sustaining a stroke, a client is transferred to the rehabilitation unit. The medical surgical nurse reviews the client's residual neurological deficits with the rehabilitation nurse. Which neurological deficit places the client at the greatest risk for skin breakdown? Now, again, all of these clients could be at risk for skin breakdown. That's not what the question is asking you. The question is asking who is the greatest risk for skin breakdown. Okay.
B.
And I see a lot of B's, B's, B's. And yes, that
Yeah,
is the
B's.
correct answer. B. Okay. The person is incontinent and they have right-sided hemopharesis or right-sided weakness. They might be a little bit of, paralysis. So they're not able to move too much on their own.
Mhm.
Because of those 2 factors, this person is the highest risk. The
Yeah.
others might be at risk, not saying they're
A,
not.
A take a little while to come in.
Huh?
I said A take a little while to come in, the skin
Yes,
break.
let me see. A, inability to express need for repositioning. Honestly, they don't even have to say anything. As the nurse, I should know my client needs to be repositioned every 2 hours, reduce the risk for skin breakdown. So they don't even have to tell me. What if they're unconscious? and they're not going to say anything. Do I not reposition them because they can't tell me? No, you have to be able to recognize the risk for skin breakdown, even if your client is not able to communicate.
Yeah.
Okay, good job. Question number 5. A client has been admitted to the hospital following a concussion. Which nursing interventions are important while caring for this client? Select all that apply. So this is a traumatic brain injury, concussion.
C,
So
D, E.
C, D, and E. Let me see what's going on in the chat.
CDE.
I see B, C, D, E, C, D, E.
CDE.
Somebody is confident the answer is CDE. Yes. Okay. So remember, safety is always the priority. They could start having a seizure, okay, because they have a traumatic injury. I'm going to go back to the answer. So everybody did not pick A. Oh, I didn't see any A's. Let me see. Some people still in the chat. Okay, good. No A's. You do not want to heavily sedate this person. You need to do neural assessments. I need the person to be as functional as possible for me to get an accurate assessment. If I heavily sedate this client, I'm not going to get no. I could probably shine a light in their eye. That's about it. But everything else, I'm not going to get a good assessment if they're heavily sedated. Their eyes might not respond because they're so heavily sedated. Okay. Now, B, some people did pick B. Now, here's the thing. Not saying that B is not something that I would do. It's just in the beginning, there's nothing in this question that indicates this client needs to be NPO. Okay. Remember, the person has just been admitted. They have a concussion. This could be a very mild concussion. Okay. No need to restrict the diet right at this moment. Okay. Only if there's an indication that there's possibly an aspiration risk would I put them NPO. But there's nothing in the question, even though they have a concussion, there's nothing in the question that says they are an aspiration risk. Concussions is just temporary memory loss and confusion. It doesn't necessarily say the person is an aspiration risk. So that's why B in the beginning as an important intervention is not the correct answer. Okay. Question number 6. A nurse is communicating with a client who has aphasia after having a stroke. Which action should the nurse take? So if you remember, we talked about aphasia, strokes, that is inability to communicate effectively, whatever that looks like. So if I have a client that is experiencing aphasia, how can I help communicate with this client? I see a lot of D's, a lot of D's, a lot of D's. And of course, the correct answer is yes, D. Okay. Now remember, now remember, the client is not deaf. Okay. So standing in front or speaking loud, over pronunciating, not necessary. Okay. All it just says is the client has trouble verbally possibly communicating, or what if they can't write anything? But if they're able to at least see your mouth move and you talk clearly, okay, talking slowly and enunciating, that could be offensive. Talking very slow and over pronounce, that's unnecessary. You don't have to
They
do that.
might feel like they're a child.
Oh, and that's why I said it might be offensive, and we do not want to offend. And the person probably like, why are you talking like that? You don't have to talk like that. That could be offensive. Switching topics frequently. Listen, you don't want to aggravate the person. Why would I be switching topics, talking all over the place? You got to they just had a stroke, so you got to give them a little moments to catch the thoughts. You got to give them time to respond. Whatever way they can respond, we need to give them time to respond. Talking in a louder than normal voice, they're not deaf. They just had a stroke, but they're not deaf. Okay. Question number 7, dosage. Of course, there's dosage on the NCLEX. People tend to forget. You got to know your dosage. So, healthcare provider orders carbamazepine, 200 milligrams orally 3 times a day for a client who has epilepsy. The dose on hand is 100 milligrams per 5 mLs. How many teaspoons will the nurse give the client at each dose? So, a little trickery up in here. So, your order 200 milligrams orally 3 times a day. So we know we're giving this medication 3 times a day. However, the question is just asking you how much would you give each
2.
time. Sometimes students get tripped up on the wording.
2
On hand,
teaspoons.
2 teaspoons. On hand is 100 milligrams. This was an easy conversion. 200 milligrams ordered, 100 milligrams per 5 ml. So I need to give 200
10. That's
10
10 and
mLs
then
or A, 2 teaspoons. Perfect. I
Mhm.
think everybody got that right. I'm looking in the chat, looking in the chat, looking in the chat. Perfect. Good with the dosage. Okay. You got to be comfortable with dosage. You never know if that's going to pop up on your NCLEX. I had dosage on mine, so it's there. Okay. So as long as you guys set up, you could do dimensional analysis. Oh, you could do dimensional analysis or the basic setup, which is what you see explained here. Ordered versus what's on hand. 10 mLs. That means you need to know your conversions. Okay. 5 mLs and 1 teaspoon. So I'm giving 10 mLs. So I'm giving 2 teaspoons. Very simple conversions. Is the dosage going to always be easy like this? Probably not. But this gives you an idea of what dosage would look like.
I wish
Question
we have
number
more math on there.
You guys want to do more math?
No, I said I wish we would get a lot of math on the NCLEX.
Oh, you comfortable with math? See,
I'm
okay.
very much.
No, ma'am. You're total opposite of me. I'm not. No, ma'am. Don't like math. So
I
listen,
love
I
it.
had two dosage questions. That was it. And I was so thankful for the 2. And I was like, well, I must have got it right because I ain't seen no more. Question number 8. The nurse. I do not. I'm not mathy at all. The nurse is caring for a client who has been diagnosed with a brain tumor. Which assessment findings are recognized as early signs of increased intracranial pressure? Select all that apply. So I already see some answers in the chat. I think I saw A and E.
Yeah.
I see AE, ACs. Who else? So remember, early signs is your key.
And E.
I heard AC and E. So ACE. Okay, let's see. What are our early signs? Yes, AC and E. So going back, headache, irritability, dizziness. Okay, very subtle early signs. Okay, headache, your pressure could be high. I don't know why you have a headache. Okay, irritability, you're just irritable. And then, of course, the dizziness. Very, very early, subtle signs. That's why I said sometimes you might even miss it. Now, fixed and dilated pupils, that is never a good sign. Okay, when it comes to trauma, that person is probably not savable. Because I know you guys heard of the whole color triaging and stuff like that. Fixed and dilated is never a good sign when it comes to electrical brain activity. And decerebrate, we talked about posturing. Okay, both of those are signs of traumatic brain injuries. Definitely could be a late sign for increased intracranial pressure. Good job. Question number 9. An adolescent is at risk for injury related to intracranial pathology following a motor vehicle collision. So in a fancy way, risk for a traumatic brain injury related to car crash. Which nursing action is the priority? Again, when you choose an answer for prioritization, you're not saying the other answers are not important. What is the most important? So I am seeing, I'm hearing B's and I'm seeing B's.
C.
B's, B, 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 B. And of course, the answer is yes, B.
B.
Okay. B, they hit their head, motor vehicle accident. Think of Natasha Richardson hitting that tree. I need to start monitoring your neuro status. Increase. If I see your pressure around the brain is increasing, that could be a sign of bleeding onto the brain, which is what she had. So that is a way for pressure to build up. Fluids around the brain, cerebrospinal fluid, blood, all of that can increase intracranial pressure. Cerebral edema can increase intracranial pressure. So yes, me monitoring intracranial pressure is at the top of the list due to the nature of this kid's injury. Oxygenation and temp, very important, of course. However, okay, at this moment, it does not say in the question that the kid is experiencing respiratory issue. See, when you answer questions, you got to pay attention to what's in the question. You always think airway, breathing, circulation, airway, airway, airway. So, of course, oxygenation would probably trigger me to pick it, but it's nothing in this question that says this person is experiencing a respiratory issue. Okay, maintaining the head in a neutral position, that could inadvertently raise the pressure, and then maintain normal glycemia and normal tension. So, I mean, it might be important to regulate the blood glucose and insulin and things like that if necessary, but that does not take precedence over monitoring for increased intracranial pressure. And last but not least, the nurse cares for a client with a sports-related concussion. What is the best way for the nurse to assess the client's orientation? So this is going back to fundamentals. How do I assess orientation? My client has a concussion. Now, you might be looking at these answers and be like, it's about 2 of these that look right. It could possibly be 2 of those
A,
that look
B.
right. So this is not select all that apply. This is one answer.
I would go with A.
A.
Okay, I heard A. I see a little bit of mix. I see A, I see D, I see C. So we kind of all over the place with this one. I saved the best for last. The correct answer is A. Now let's go back and talk about why A is the correct answer. So first off, when we assess orientation, okay, you're talking about time, place, times 3, orientation times 3. We always see that person, place, and time. Okay, so the best way or the most effective way is for me to pick an answer that assesses as much orientation as it can, and that would be A. Asking the client to describe the events. Listen, that's memory. Do you remember what happened earlier? That's not assessing orientation, like in the present. Okay. C, ask the client, know their name and their spouse's name. Now, that's orientation of person. Okay. But what about time? What about place? Ask the client if they know the date, including the year, day, and month. Again, orientation to time. But what about person? What about place? Okay. Because when you put orientation times 3 or alert times 3, I'm saying I assess person, place, and time. A kind of addresses all of that. Ask the clients if they know where they are, if they know what time it is. So that addresses 2 out of the 3. That is a better way than just C and D. C addresses one aspect, D addresses another one aspect. A kind of combines 2. Now, I can make A even better and I can ask the client, can they tell me their name? Do they know where they are? Do they know, what month they in? I can ask 3 in 1, but A does cover 2 out of the 3 orientations. So A is the better answer out of the other options. Okay. And that is it for our presentation. Does anyone have any questions? Now, while we are finishing up, you guys, I am going to post a link in the chat. Okay.
Thank
You
you
guys
so much,
know
Prof.
you
And
guys
good
are
night.
so welcome. But before
Thank
you go,
you.
you guys click that link. The link is there. You're so welcome. Look at y'all. Y'all so sweet. You're so welcome. Click that link, leave your feedback. I always like good feedback. Constructive criticism, I like it all. If you see something you want me to do more of, less of, please leave your comments into the chat for the link that you post. You're welcome, you guys. You're so welcome. You're so welcome. Any questions for
Thank
anyone
you
that's still
very
sticking?
much. God bless you.
You're welcome, Miss Patience. You have a great night. Thank you guys for being very active. I
Thank you
like
so much, Professor.
You're welcome, Miss Juliet. So if there's no questions, then this is concluding our webinar. Again, make sure you click the link. I'm going to post it again for those of you who didn't catch it the first time. Click the link and leave your reviews, please. So if you guys will be joining me again, I have another mental health. It's going to be Sunday night. Off the top of my head, I'm not sure what the exact topic is,
We'll be
but
there.
every Sunday
Thank you,
or Monday, one of those
Professor.
days.
Thank you,
Sunday, Monday, one of
Professor.
the days. Yes.
Thank you. Bye.
You're so welcome. You guys have a great night. I will see you guys Sunday or Monday, one of those nights. I'm not sure which one.
Thank you.
Okay.
Have a good night.
You're welcome, Miss Jen. Beautiful picture. You guys have a great, 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 great night.
Thank you. Bye.
You're welcome.